Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. Well, welcome everyone back to another episode. Today I am with Dr. Joshua Campbell. He's an oral maxillofacial surgeon practicing in Tennessee. Josh, thank you for joining us on the podcast.
Thank you. Thanks for having me. I'm excited to be a part of it.
Yeah, I think we have a good topic, good discussion. Just to start things off, can you just give us a brief history of your training and your current practice setup?
Yeah, no, absolutely. So I'll start with dental school. I went to dental school at Iowa. And then third year I was looking for I thought I was gonna do general dentistry, and then in third year I was in clinic. I think it was Dr. Sinan, and we were working on a case, and I'd never seen a tooth taken out before, and it was amazing. So, and I didn't really venture up to oral surgery. The oral and maxillofacial surgery department, and even when I was rotating with the general dentist in my hometown, it was just like fillings and cleanings and stuff like that. So, but anyway, it was great, and I was like, I want to do this, and talked to Dr. Sinan, and Dr. Liu was there at the time, and Dr. Burton. They said, you got to go down, check out University of Tennessee in Knoxville. The program's a little bit different, and I did, and I spent 5-day externship there, and I didn't really sleep at all. I started to get like lymphedema, in my legs and everything, and I was loving it. Like, I mean, you constantly had something to do, and Dr. Andrew Chung was the resident at the time that was kind of leading me around, like, hey, let's suture this, let's do that. So really fell in love with the place. And East Tennessee too. It was really, it's really a neat area. I'm originally from Minnesota, and it had lakes, it has beauty, it's got mountains, all that sort of thing. And applied, and they accepted me there. So I went for the 4-year degree program from 2004 to 2008, graduated, and then I was out in private practice for a while in a group practice, and then transitioned to a full-time academic in 2015 for about 3.5 years, and did dental alveolar implants, trauma, and then covered for the chair for a little bit there at the department in Knoxville, and then transition out to private practice, and I'm part-time at UT. So I do get to spend typically Fridays at UT doing cases that I bring over, and then working with the residents, and help with journal club, help with interviews, help with mock boards. So, and practice in one of the suburbs of Knoxville, Farragut, Tennessee, and my practice is Farragut Oral Surgery.
Awesome. So cool. Well, thanks for running through that.
Yeah.
We wanted to talk a little bit today on kind of some of your grafting techniques,
Sure.
and implant type stuff. In a prior conversation, we had been talking, and you had kind of explained how over time you've evolved to kind of more simplicity with your grafting. Can you just talk a little bit about that?
Well, so I was trying different products, and there's a whole bunch of things out there. If you want to graft, you can find a lot of different products and techniques, and different things like that to graft. And so I did that, and I've tried block grafting, tibial, bone for sinus grafting, and just over the years, seeing different things, whether it's things that happen on my patients or other patients. I always try to keep a note of that, and from tibial plateau fracture to block grafts that pop off when you're trying to place an implant, or don't ever integrate to begin with, uh, to flaps that basically flap open. I started thinking like maybe I'm approaching things. Maybe I need to approach some of this stuff differently because this isn't as predictable, at least in my hands, when I'm doing things. So
Yeah.
uh,
And so how with your like normal grafting, have you found success with a kind of more simplified approach, because I think the tendency, of course, for like of course the various companies who produce products is to like more stuff and more membranes, more screws, more,
yeah, yeah.
product because they want to sell. But what's been your experience there with having success with maybe kind of simplifying all that?
So the one of the biggest things that helped me, other than seeing things that didn't work great on patients, was I took a course by Pat Allen in Dallas, and it was the tunnel grafting for soft tissue because I'd done a lot, done implants and bone grafting and different things like that, and I wanted to make sure that I was up on the latest techniques for soft tissue grafting too. So this was back 2009, 2010, something like that. Took the Pat Allen course and used Alloderm to do tunnel graft technique for recession. Well, during that, I'd seen tunnels with, various materials, HA and different things, and that kind of left me with a bad taste in my mouth. But started considering doing tunnel grafting though for some of my patients, not using HA but using cortical cancellous bone, and so I decided to start doing that after did a few grafts for recession and for implants, and decided to use the technique for bone. And so had atrophic maxilla, everything from the atrophic maxilla to a site 7 or site 10, you can tunnel graft very nicely in the maxilla. It's a little bit harder in the mandible, but you can do that in certain cases. But in the maxilla, what's really nice about it is people can have a bridge, they can have their teeth in place, they can have different things. You basically make an incision kind of right where the frenum is, and you can pack a whole bunch of bone through about a centimeter incision, right, left, as much as you want, pack it all the way back to where the sinus would begin, and you can create a huge tunnel of bone in the atrophic maxilla. So, and that combined with other things is pretty powerful. You look at Tara Egaloo, she talks about the nasal lift. You can combine that, into other things if you want to. I've done split ridge technique through that opening, and then you can pack bone between the buccal and lingual cortices, and you can take your osteotome and you can drive it all the way back to the sinus and include sinus grafting in it as well. So you can create this really massive amount of bone, and you're packing in cortical cancellous bone. I usually use Mineros or Gen 8 for that particular technique. So
Nice. And I know you mentioned that you use the OsteoGen plug in certain situations. When
yep.
would you use that?
So the OsteoGen plug is nice, and that's something that I've added recently. There's a whole bunch of things that I'm not using anymore. It's unusual for me to start adding things back in, but that was one thing that I have added in because one thing that I do see with the cortical cancellous bone is sometimes you can get the chips of the bone spitting out, and can sometimes be a little bit harsh, maybe get some inflammation. So I like to use the OsteoGen plug in certain situations for coverage of cover screw. You can use it for that. You can use it for the jump gap, in an immediate implant scenario where you're extracting, placing the implant and pack that in, and don't feel like I get as much inflammation in those areas. And then also I'll use it in third molar sites. I'm not as concerned about the nerve, with that, because you got the collagen component, as well as the calcium phosphate component as well. So, but I think there's a lot of applications that you can use it for. I've been using it more and more. I know when we were talking, you'd mentioned that you use it in the sinus. I've used it in the sinus. It's very,
Hmm.
very gentle on the sinus membrane. Just wherever you can find a more of a gentle spot for it. It's nice. It's nice to use that. And I've dubbed it for in my practice. I got to OsteoGentle. So instead of OsteoGen, OsteoGentle, right? So, but it doesn't have quite the holding force. Like if you're doing like a tunnel graft, I can use it for one of the walls to pack against. I still have to use cortical cancellous bone for that. So, like for example, if we're doing number 7, I'm making an incision in midline. I'll sometimes make it a little bit closer to the number 7 site. But you never want to make the incision right over where you're grafting. That's the whole principle with this, and that's one thing that I feel like with some of the grafts, like we make these incisions over the ridge, and we make this big flap, and then we put things in, and we expect things to just hold solid. And when you do that, you have what I call a flappy flap, right? A flappy flap, and we're trying to relieve tension and this and that like that. What's beautiful about the tunneling technique is that the more you pack in, the better the graft, the bigger the graft. With a flap, the more you pack in of bone graft material, the more that it can fall apart potentially because of tension. So your tension is good and gets you really good bone grafting with that tunnel graft. I mean, it's more of what I would call snappy flap, right? So snappy flaps are happy flaps. Flappy flaps are crappy flaps, unless you want them flappy, right? So I tell it to the residents all the time. So I'm trying to say something that's memorable.
Yeah, that's so good.
Yeah.
Way to teach it. So, for example, if you're doing, let's say someone comes in, they have like number 7 or 10, super atrophic, narrow spot. And they want an implant. Are you tunnel grafting first and then waiting, and then you go back and do an implant or
Typically
implant?
tunnel grafting first. Yeah. So
Okay.
that's one thing I found out with patients. Sometimes we're in like a hurry, like, hey, we got to do all this all at once, right? So, but there's a concept of stacked risk. Stacked risk. I recently heard a lecturer talk about bone grafting, and he's like, well, I put a little bit of this bone, I put this in, and I put this in. Again, I'm not trying to call anybody out. I'm just saying I put this in, I put this in. I figure more is better than less, right? And that's absolutely like the opposite of my philosophy. So the more stuff you cram in, the more stacked risk that you can have with any procedure that you do. I mean, in if you do an implant, that has a certain amount of risk to it. If you do a bone graft, that has a certain amount of risk to it. If you have do a soft tissue graft, that has a certain amount of risk to it. So if you have a patient that maybe is a poor healer, and that may not be the time to do everything everywhere all at once. It might be a good time to say, hey, you know what? We're gonna do this tunnel graft first, and we're gonna check our tissue out, because sometimes doing the tunnel graft, the tissue responds good to it, and you get a good tissue response, and maybe you don't need to do the soft tissue grafting, right? If you need soft tissue grafting, you can do that, and you can do that in a tunnel fashion as well. So just like I learned when I did the Pat Allen course, and then um, then you can come back and place the implant. So I I try to look at it. Sometimes you can place the implant, but you gotta look at it. Okay, if I place the dental implant at the 7 site, and now I've made this flap, is it a mini flap, or is you talk about mini flaps, or is it a bigger flap, right? If it's a mini flap, maybe you can do that and still do the tunnel, right, and still get that contour defect, right? But if you're doing
Yeah.
more than a contour defect, then I probably do the contour defect first and the grafting, and then place the implant second. So just to reduce the stacked risk. So
That makes sense. And when you do the midline cut, you tunnel to 7. I mean, how necessary is it? Do you like tunnel past 7? Like, I'm just trying to think of how much
So,
you
so you
tunnel.
can define it as far as you want, but yeah. So what I typically do is I'll make an incision, and then you got to make sure you're subperiosteal. That's probably the biggest issue, right? And
Yeah.
so there's only one instrument that I like to use for this, and it's called a Molt 4. It's a Molt 4. And I can send you the info so you can put this into whatever description if you want it. But I can give you, there's a few instruments that are just critical. A Molt 4, U-Freedy Molt 4 is very specific. And then there's one other instrument called the bomb. Those two instruments I give out to the residents when they graduate. every year, because those instruments I think are critical. So, and in fact, I had a resident who graduated this last year. His instrument, he needed another one. I actually I got him another one because he liked it so much, and got him the number. He just wanted the number, but I'm like, here, just take the bomb. Here's the number for it, and then now you can order however many you want. But the molt is really good. It's really good because it's a little bit sharper. It doesn't have a point at the end like with the number 9, and you're able to really direct and get the end of that instrument in, and you're able to really feel if you're down on the bone properly. So you get under it, and then you can feel it drop into the depression, and then you can feel it come up. And then I basically take a freer in, and I put that in, and I turn it, and then I pack along the freer and pack bone in, and then pull the freer out. And then I take my molt again and I run it just like I'm trying to make that tunnel again. So you just keep doing the same thing over and over. It's the same thing like with the sinus graft. I always talk to the residents when I'm teaching with the sinus graft, you're just doing the same movement over and over. Like, we're not trying to push bone up into the membrane. All we're trying to do is do the same movements we made to lift the membrane every time after we put the graft between it. Because if you do that, then the sinus lift develops itself. If you do that in the tunnel graft, the tunnel in the graft develops itself, because you're pushing it out, and that's kind of creating that tension out around the periphery. And then once you get that, then you can do the final pack in the center of it, and then you can take your OsteoGen plug if you want to, or you can take a collagen membrane and put it on the other side. So I kind of put a barrier to the one side, and then a barrier to the side where the incision's at, and then suture it up, suction any debris out of there so we don't have bone chips spitting out. And I do all the suctioning because I really check and make sure that there's nothing right around the incision, and then just pass the suture twice, tie down. I always talk to them about passing the suture twice for that stitch. And when we do wisdom teeth too, I usually just suture the lower, and always pass twice for that too. I don't feel like a single interrupted suture is super helpful. Like, at least when I'm doing my wisdom teeth for closing up a lower third. So pass it twice, tie, and it just cinches it down. And I learned that from Dr. Hudson, who has recently retired from UT, but he was always a big fan of passing it twice, and I get it. So
it's kind of like a figure 8 type thing.
Yeah, it's a figure 8. Yeah, is what it is. Yeah. So,
and at your tunnel graft midline incision, because I'm picturing where you're closing the incision, like now that incision site, like towards the 7, is thicker. Do you tunnel back toward like 9 or whatever the other way to get
you don't have to, because it depends on how you put the graft in. So typically, if I'm just focused on 7, I'm gonna keep that graft over in that 7 site, and then it drops down at the 8. Yeah, it'll look like a half a golf ball. Yeah, and it's under somebody's lip. It's that substantial. So you do have to warn the patient, like, hey, you're gonna have this lump for a little bit. And that's good, but it's gonna drop a little bit. It'll settle, over time. I always talk about there's a 30%, at least minimum of 30% resorption of that lump. And I do tell them you can massage that area. It does not typically cause any troubles for a 7 or 10 site if they massage it. Now, if you're doing like a whole atrophic maxilla and they're massaging it, that's not as bueno. So
yeah, that's really
helpful. Or
helpful.
if a denture is pushing on that, that's not great. So
yeah, that would make sense. Try to alleviate any pressure on the graft.
Yeah. So sometimes people go without a denture, in certain cases, not all the time. If you're doing like an atrophic maxilla for a little bit, they can. They don't have to. A lot of times people do fine with like a flangeless denture.
Right. And when maybe switching gears to like the topic of narrow implants and atrophic jaws, because there's that you're on the cusp there of thinking, well, do I graft and try to bulk it up, or do I work with what I got and do a narrow implant? How do you make that decision?
So that comes down to treatment planning and kind of, how do you approach different parts of the jaw, right? Like in things. And in particular, we talked about atrophic maxilla, but this is the atrophic mandible. What I see a lot of times, I get a lot of atrophic mandibles that come through my office. And typically their story is go, they said to go down and see you, and I've been told multiple places that I can't have implant. I mean, you hear that a lot, but usually that is said from, a quick clinical exam, more than likely, and then a panoramic X-ray. So if you do both of those things, a panoramic X-ray can look very bleak, I guess is probably one way to say it, right? So I always say, like, every patient, it doesn't matter if they're just atrophic mandible, deserves what I say, a cone beam CT and then a workup. You just do that. If you do that, I've been shocked, and we've been able to treat most people if you just go and you plan, right? So the one other thing that I have added over the years, or I've switched to, that has made a big difference in my practice, is Southern implants. Southern implants. I use them almost exclusively, and I've just seen over the years where people just place the implants where the bone are. This is where the bone's at, or we're going to try to bone graft, and then we're going to place them where that bone is at. It's really critical that you get implants in the bone. That's just important, right? We know that. But then it's really, really important that we get implants in a position where they're usable too. So I can't tell you how many cases that I see now where I'm having to take implants out that were placed either a long time ago, or more and more what's happening is implants that were just placed recently, and they weren't placed deep enough. They weren't placed in the right position. There was no plan. And I mean, one of the most notable is 10 implants taken out on somebody and then starting from scratch. I mean, it is just, the patient's just, about ready to pull, they're not happy. So, but with the atrophic mandible, they deserve at least a cone beam CT and a plan. And if you do that, you can start looking at, can you place implants? And if you do, what are the different criteria that you use? Because most people use it. It's just a criteria that's set from a panoramic X-ray. Like, there needs to be a criteria that's set from a panoramic X-ray and a cone beam, because the cone beam oftentimes show that there's decent basilar bone, and you got a nice triangle of bone that comes up in the center. And I just saw one this last week where we should be able to get at least three implants in for some sort of bar, working with a prosthodontist in kind of the East Tennessee area, up towards the Kingsport area that I work with. I said, I can get three implants in. He said, that's great. I can do a bar. And the way that I can do it, I can get one midline where it's highest, and then I can get two Southern implants that are angled in. And the Southern implants allow me to get a nice angle, 12 or 24 degrees, and then come up and out, and then redirect the restorative spaces up. So there's going to be, so we're going to satisfy the bone for the implants, and then we're going to satisfy the restorative components. We're not going to be on angled abutments. They're all going to be straight abutments that he's going to, even though the implants are angled. And if the people listening aren't familiar with them, I encourage them to look at what those implants. They look like mini zygomatic implants, and you can do things with them. You can have a tooth that comes out here, and let's say the tooth that comes out here, and the implant can be going in any one of a three-dimensional area, 12 degrees, 24 degrees. It's straight. They have straight implants, 12, 24, right? And even 55s, right? The 55s are zygomatic implants. So, but right. when you do this, when you do an implant on a mandible, one thing I feel like that people don't think about is diameter. So there's only so much bone, right? There's only so much bone. So place your implants not under tension, and in a narrow diameter, 3.25. I've done some 3.0s as well. So you're leaving as much native bone as possible. And then and then don't load it immediately. Do not load it immediately. So I'm currently managing a patient in my practice who was seen elsewhere, and was a loaded atrophic mandible, and I think they would have been fine if they hadn't loaded it. So, but it was loaded, it fractured, and then I had to get a custom plate and put it on, and we're working through the healing process right now on that. So, and it ends up being something that could have been, fairly quickly, or not quickly, but something that would have taken maybe a year to get to. It's going to take a couple of years now to treat this patient, if not more. So, that sort of thing. But narrower implants are typically one thing to consider. There are times, if it's just, if we're, under, that 8 to 10 millimeter mark vertically, where I will put on a bone plate, a custom bone plate, and then place implants, narrow diameter in the jaw. I was trained to do a tent pole technique for that. I typically don't do that anymore. So I haven't seen the need to do the tent pole as much, or these other massive grafting techniques that people do. Typically, I try to use the bone that is there with or without a bone plate, and narrow diameter implants in the mandible.
Okay. And the bone plate is for like mitigating fracture or just stability?
Yeah. It's to help with preventing fracture on certain patients. Yeah. So
Okay.
if you've identified them as heavy bite, um, there's some, or you're just so thin that you, especially kind of over in the body area, you still have good bone here.
Yeah.
I mean, there are some patients that they just don't have anything up here, and you've got to do some sort of graft, right? And then typically I'll consider like a tent pole technique if we're going to do that. But if this is super thin and they have a heavier bite towards the body, then I'll run a custom bone plate over to the side and then place implants. And you can do the custom bone plate and the implants at the same time in the OR. So that you can do it typically same time.
Oh, nice. That's pretty slick. How about just talk to us a little bit about like guided versus freehand decision making and how do you
So it's interesting when talking about guided surgery. I talked about it at the December implant meeting. I think it was like 2019. It's been a minute now, so if I'm recalling that inappropriately, but I was doing a point counterpoint, and I was supposed to define guided surgery. So, and it was interesting. I had an opportunity to think about it and talk through it with someone that I work with a lot, Dr. LaCasio, who's a prosthodontist here in Knoxville, and the best that I could come up with for what guided surgery is. And I feel like it's my working definition for guided surgery is I need a cone beam CT, I need a plan, and then I determine the level of guidance.
Okay.
And determine the level of guidance. Everybody has a different definition of guided surgery. So some people it's a robot, some people it's XNAV. Some people it's you got to place the implant through the guide, right? And then others are, well, you just have to use the guide for drilling, right? So, but I see guided surgery as a cone beam CT, a plan, and determining level of guidance. And oftentimes for me, I use anatomy for guidance now. And I used to use printed guides a lot. I was probably 70-80% printed guides when I first started out, and I felt that was good. It showed me, okay, this is kind of how I would position that or do that. But over time, I switched over to using the anatomy for guidance. And I remember the sentinel moment, the time that it switched. It was one time we weren't able to get a guide, and I can't remember if it was like a volcano in Iceland that delayed it because I was using a lot of Simplant guides. There was one time that happened, but there was something that happened where it just wasn't going to make it, and we needed to do this case for whatever reason, right? And I looked through the scan, and I had a plan, had a cone beam, had a plan, and used and just measured everything, all the different references, and did the procedure, and it turned out like I would have guided it, like, because I've done enough guided cases. This is what it would have looked like. I'm like, oh, maybe I can do that. I can use anatomy for a guide. So that
Yeah.
but I don't think that getting out of residency, you're going to get that right away. That took me a few years to get to that point. I think it's good
Right.
to rely on guides and different things until you get a comfort level for where your cutoff is. I need them up to this point, or I need them for that. I need them for this. And everybody's going to be a little bit different with that. The big thing I'd say with any technology, and I tell the residents this, any technology you use, do the simplest thing you can with the technology first. Because look at like a navigated kit. I'm very familiar with the 3i Navigator kit, but I wasn't when I first used it, right? Everything is like, well, here's what's that and what's this. I see a lot of people say, oh, I got this really difficult case. I'm going to do this guided because this is really difficult. And this is the first time I'm using the guided kit, or this particular guided kit, or this system, or that, right? That's not the
Yeah.
time to do it. That's not the
Hmm.
time to do it. You have to use that on something you would never even think about guiding. Use it on the simplest thing. Use it on a single implant first
Hmm.
time, just to get a feel for it, so you know how it works. There's a whole host of things that your guide can break. I've had that. Your burrs can stick. You can. I don't. There's. You can get stuck on the teeth. The guy. There's a whole bunch of different things that can happen. So that
Yeah.
it's just you can have just chaos reign, and the more that the more complex the case, the more chaos it's going to be. And then what happens is you blame the technology when the technology's fine. You blame the lab when the lab's just fine. Like when something goes wrong, that's me. That's me. It's
Hmm.
not, it's not, it's not the technology. It's not the guide. It's not the lab. It's me. Because I understand how the guide was made. I understand its limitations. And I have a cone beam CT and a plan, and this is how it should look when I'm done.
Yes. Love that. That's such an important concept.
Yeah.
Kind of simplifying, using really complex technological
Yeah.
tools in a simple situation first.
First. Yeah. Yeah.
Yeah.
I think that's really, really critical, and I think it's overlooked. It's overlooked a lot. So I
Yeah.
overlooked it when I was first started. So, and I realized, what am I doing? And when I did one of the, I think it was the first guided or planned orthognathic case at UT. And this was way back, I don't know, 2010, and it was when Simplant had Simplant OMS, where you could make all the cuts on it and do it all yourself. I did the whole workout myself, where people sit and engineer does this and that. Like, I did the whole thing myself, and I decided to use it on prognathic case setback. Like, you don't need to do that for a prognathic case, but I wanted to do it because I wanted to see what it looked like. So and I found out a lot of things. I found out that you in literature, you have a lot of conventions, like, here's the nerve is here, the nerve is this, the sinus is there, the IMAX is here. Like with a workup, you don't need any of that. You don't need the averages, because you have the actual. Like,
Hmm.
this is where it's at. Like, have all your measurements set before you go in. Know your patient. Walk in, have them written out. I cut this far up. I do this. I do that. It's interesting. I would be curious, even in my cases, like, here's where I planned the implant. I placed the implant. Did it actually go where I planned it?
Yeah.
Right. I think we need more of that. Like,
Mhm.
I moved the maxilla. This is where I planned it. This is where I moved it. Did it go where I planned it? I think you would find out a lot of maxillas and different things, like, they're not quite where they may not even be. They're closer than what you could be if you had any plan at all. But I see a lot of maxillas that have rotated down because it just didn't get enough of the posterior, of the maxilla removed to impact it far enough, and then that rotates the lower jaw a little bit more. I think it'd be interesting to do it, to follow that up and see how we do with different things, like, what's the outcome. Are we truly getting where we need to be? And then with dental implants, you get even further. You say, all right, so this is where I planned it. This is where I placed it. This is how the patient actually got what they intended to get with the restoration. And now the restoration has survived X amount of years, right? So that, I mean, those different things I think are really, really important. And then I think that's where AI comes in and says, hey, I would suggest this or suggest that, right? For replacement. I don't think AI is going to have a hard time replacing us, but I feel like that's those are things that we need to be looking at for improving our outcomes and making and helping our technological decisions. Like I was using this graft or did that, and it's just that that wasn't the best thing I could have done. I could have considered doing this based on X amount of cases, right? That sort of thing. So, and just get suggestions in real time on your patients.
Sure. Yeah, I love that concept of kind of always being a scientist, looking at how it went, thinking about why it may varied from your expected or planned outcome.
Yeah, yeah. But I'm hoping that things head that way, and I feel like they are in a lot of respects too. I mean, people are working on that sort of thing. So um but yeah, so there's a lot of things that I don't use anymore. I've given that lecture to the residents. I've also given the $1 million implant lecture to the residents. That was a fun one where you can place an implant for $1 million if you want to. So, or you can place it, you know, with a cone beam CT, a plan, and then whatever it is that you actually need to do it. So, but there's a whole bunch of things you can buy to place an implant, and do you really need all that stuff? And there is a winnowing process that we go through. Um, I'm happy to talk. I could talk for a long time about the things I don't use anymore, things I don't use anymore. So, and stuff that is being used a lot that I just don't, because I don't feel like it helps my outcomes in the way that I approach the different segments of the mouth. So, and but there are some things that I've added, and I've added OsteoGen plug. I've added that, and
Okay.
I've added Southern implants, or I've swapped out Southern implants because I feel like I'm a specialist, and it allows me to do special things.
Nice.
Allows me to do special things. So they have a lot of, even their zygomatic implants. I mean, Strawman contracts for them because they're just good implants. They're good zygomatic implants. I say that I don't use zygomatic implants hardly ever, because usually I can talk to the patient about, hey, let's go ahead and well, first of all, you do the scan and the plan. Typically, you can find places to put implants even without grafting, and patients who have been told you can't you can't have implants. But typically, I'll try to do sinus grafts first. And if you do sinus grafts, a lot of times you don't need zygomatics. So I just don't have a huge need for that technology from Southern. But I do have a huge need for their mini zygomatics, right? Their 12, 24 degree corrected implants. So,
Yeah.
but yeah, I could keep talking. Grant, you're thinking of something. I keep talking. So
No, this is helpful. I mean, I can relate. Um, I've been out of residency 10 plus years.
yeah,
Certainly there's been a winnowing process. I mean, and sometimes it seems like almost technological things that are supposed to make it easier, better, whatever it is, can actually do the opposite. And so
yes,
it's
yeah,
like, gosh, yeah, trying to sift through all that and figure out what really is the most helpful thing can sometimes take time and
it does
effort.
take time. Yeah. Um, But I do know that Molt and that bomb, they're great. So if
Okay.
anybody wants that link, I'll get it to y'all. Those two, and then um, I'm just thinking of all the different like even like the piezo. I don't use a piezo. I don't use a laser. Don't use PRP, PRGF anymore. I mean,
Okay.
I've tried all that stuff. We've had XNAB. I don't use XNAB anymore.
Anything with your third molar techniques that um, you've changed over the last couple of years because you found something worked better or and then
So,
each
so
suture technique?
yeah, so I think I may be, I don't know, I may be a little controversial. I do a lingual flap.
Okay.
I do a lingual flap, and I don't I don't know of any permanent injuries to the lingual nerve with that. I'm doing it for a long time. And the person that I learned it from was Travis Witherington. And he's also the one that told me about the bomb and the mold. So, basically, and there was a time that I wasn't doing suturing at all with my wisdom teeth, not at all.
Yeah.
Um, for a long time, I started doing it because I felt like there's a little bit of value to the lower. I do not suture the uppers though at all. I mean, and it's the concept of snappy flap.
Yeah.
The uppers snap back in, right? I don't
Yep.
do any releases. I don't like releases. I feel like releases are where pain comes from. The reason that I like doing a lingual flap is for really difficult wisdom teeth. For really difficult wisdom teeth, like you can flap to the buckle all you want, but you just keep making this big hole, right? And oftentimes for difficult wisdom teeth, the hole has to be huge, and you're trying to pull it out kind of through the side, and you end up with a massive defect behind the second molar, right? So and then you talk to him about, well, we might have to take the second molar, right? So because this is just really, really difficult, right?
Yeah.
Well, I mean, and also increases chance of fracture, that sort of thing. But if you can split the difference of the opening, you're not getting all that opening to the cheek side, all that swelling post-op, everything. But you're able to open up and you're able to see kind of that look that you'd have for an osteotomy, right? So you're looking up the ramus, and it kind of looks like a triangle with the base down towards the second molar, and then it goes up to the apex, right? You can remove all that bone. And one thing I talk about with the residents is like, don't drill deep. You're just decorticating the bone. Like the tooth will move through the marrow. Like you don't need to drill all the marrow out. That moves when you elevate the wisdom tooth, right? I mean,
Yeah.
so if you just decorticate between the external and the internal oblique ridge, you've got this massive trough to just tilt a difficult tooth out of. And so then the next thing you do is you go in, you just split it so you have the mesial and distal roots separated, and you just elevate it and turn um, that distal piece out. I usually have a cone beam on a really difficult wisdom tooth, right? And you just tip it right up and out, you have all this room to be gentle with the nerve, and it can, sometimes there's a little hook. It can even help with that little hook because it can help get around that. Whereas if you didn't give it space to move, it's gonna it could pull along it and tear a little bit more, even with the tip of the root, right? So
Yeah.
so you kind of tip up and out, and then you tip up the mesial. Oftentimes you can tip the mesial up without taking the mesial part of the crown off, or the crown off the mesial root. You can get under with this little point and pop it up. But sometimes I'll have to take the crown off, take that little piece of crown out, and then swing the mesial root out at that point. But I'm surprised a lot of times you don't have to. So, but in really, really difficult teeth, I'm talking about later decades. And the other thing that I've noticed later, wisdom teeth in later decades, and even if you notice with exposures on canines on later decades, I do those. The key is to them is the enamel and the bone. The bone adheres to the enamel. Like you got to separate all that off. If you separate the enamel and the bone, things come out a lot better. And I don't know, is that your experience at all with things?
Oh yes.
That's what I've seen. But I've done some like those canine exposures, and if you can get that enamel free, typically you got a shot at getting it down. But with wisdom teeth in particular, I think that lingual flap is really, really critical for very difficult teeth, and to preserve the walls, the buccal and lingual walls, when you're trying to get that out, and also to help prevent troubles with the second molar. And oftentimes I've talked to him already about, hey, we're gonna have to bone graft this, right? And typically if we do, I don't want particulate down around the nerve. right? So it's either going to be some sort of collagen,
Yep.
something that is that's gentle, OsteoGen gentle,
Yeah.
OsteoGentle, something like that, right? That's down there. So yeah.
When you make your incision for the lingual flap, are you still doing the buccal hockey stick or is it more of a
Yeah.
serrated?
So it's still so you come along the tooth, and then the second molar, and then you release distal and lateral, right? And there you always identify that little triangle where the lingual nerve is at, right? And
Hmm.
I was telling you, stay several millimeters over from that. So you just swing up with it, right? And then I just do just a little pop with the molt, so
Yep.
so you can get down on the buckle, and then I elevate over the lingual. And one thing that's tough with your lingual flap, what I see a lot of times when the residents are first learning it, is that um, you when you elevate right over where the crown of the tooth is at, it's hard to lift in that area. So sometimes you got to go back a little bit and drop off where the bone's at and then swing forward where the crown of the tooth is
Mhm.
at. And then I'll take a freer and I'll put that freer down in there. And then I'll put my Minnesota on the buckle, and then I'll just clean that whole area out between the internal and the external oblique area. And
Okay.
then you just have this beautiful view of the tooth. You can see it, you can section it, you can get it
Yep.
out. I mean, it's very organized. I like organization. It's very organized. It's not chaotic at all.
Yeah,
Yeah.
exactly. Very nice. And I would think, because maybe if you're doing a lingual flap as well, that maybe a suture then would be more critical. Because when I don't do a lingual flap at all, I mean, like you're saying, I rarely suture if it just kind of snaps back in place on its
Yeah.
own.
Yeah. So I do a suture for that. Yeah. And I usually put it just right in the point, past there, and then pass up where the release is at, and then tie down, and it
Okay.
usually seals it up pretty nice.
Just chromic, or what are you using?
Yeah, I usually use 3O chromic for it. And I usually tell the patients anywhere from 2 days to 2 weeks, it'll come out. I just give them a huge range.
Well, awesome. This has been so helpful. I love how you break things down into
Thank you.
simple concepts you can understand. Wow, the residents got to be just, that's so beneficial to have your
I,
teaching.
I, I love working with them. I enjoy it. And as long as they keep having me back, I'll keep going, I'll keep going over there. So I
So
enjoy
good.
it a lot. And you're a great listener. I know you have things you could share with me. I've just been talking. And again, this is the first time I've ever done this. So I appreciate your patience and your listening skills with me.
Oh, yeah, it's been great. This has helped me. I plan on making a couple changes myself.
Okay.
If you're okay with it, I could put your contact info in the show notes so
Absolutely.
that listeners
Yeah.
could reach out to you directly.
Yeah.
And yeah, if you wouldn't mind just shooting me some of the links to these instruments and
Yeah.
whatnot, we can put that in the show notes too.
We'll definitely do that. So that'd be good. So, I should say I need to mention Dr. Gocher. He was
Yeah,
he was there late last night at UT. We both were finishing up because our cases ended up going later. Some traumas had come in and that sort of thing. And he sat down and we just talked through just some different things. And he was super helpful. But he's the department chair right now at UT, and he's one of my favorite people. And he was if you ever need someone to talk to, he's a good one about the history of oral and maxillofacial surgery, and just
that would
about
be cool.
he's got so many stories. If you talk to him, you would have so many podcast episodes. That would be great.
The series. Wow, that's
He's
cool.
a really good guy. But he sat down and we just talked for a while during our break. So it was good.
Okay. Well, we end every podcast with some rapid fire questions. The first one is, what is the best book you've read in the past year?
The best book I've read in the past year, and this is not very rapid,
Okay.
man. Which it's probably so. There's John Lennox AI, talking about AI, and then
Yeah,
I like Jordan Peterson as well.
same.
So maps of meaning, and the rules, that sort of thing. So those are probably some of my favorites. I'm blanking on the one. There's one other one I'm trying to think of right now, but I like to read. I like theology and philosophy, basically. So and then snippets of like Dostoevsky and different things. I haven't read a full fiction book in a little bit, but yeah, those are probably the ones that have been most recent. So more nonfiction.
How about what's the most helpful kind of non-oral surgery thing you do in your daily life that helps you with your daily oral surgery skills? Is there anything
Oh,
outside of work?
oh yeah, yeah. So I like gaming. I do enjoy gaming. I think it is helpful. Like if you're into technology, I think gaming is important. And the more articles that we can have justifying it, the better. The more we can write off in our practice, that sort of thing.
Yes.
And then also pickleball. Pickleball is
Uh,
helpful. I play a lot of pickleball. I was going to play this morning, but my my team pickled out on me this morning. I guess it was too cold or something. I don't know. So, but that's one thing I do to keep um, just healthy overall. It's good for cardio. It's good for uh, your heart coordination, all that sort of thing. My kids play a lot of tennis. My kids play a lot of tennis, and I do want to get back into tennis. I just don't have the time to really invest in that. And pickleball is super easy to play, pick up, and that's one thing I do encourage people. Like you get to a point in your practice, and you're like, you go, I didn't know I was going to practice this long. You get to a point you're like, I didn't realize I was going to practice this long. If I knew that, I would have taken better care of myself, right? So it really is important. Like take good care of yourself. You get I don't sit down now, but I sat down for about 8 years, and that was probably a good thing. It probably saved my back, my neck a
Yep.
lot. I ended up standing up more when I went back full time to UT because I'm practicing with the residents, and it's a little easier to jostle around, and you're on the OR standing up. But
Yeah.
think about your body. Your body I mean, if you do something permanent, it can really affect you. So,
Oh, yes, for sure.
so
Next question. What forceps do you use to extract tooth number 14?
okay. So I use an 88.
Okay.
I
That's
use
like
an
an
88.
anatomic.
What's that?
That's like an anatomic type of
Yeah,
forceps.
so it's like a cow. It's a cow horn for the top, right? It's
Yeah.
cow horn for the top. That's what I call it. Cow horn for the top.
Okay.
Now, I usually don't get it out, right? But it's the one thing that it helps me loosen things up, right?
Yeah.
So a lot of times I end up having a section, and
Mm-hmm.
you can tell right away if that's not moving with a maxillary cow horn, you've got to stop because
Yeah.
if you're at all doing implants, you've got you just and I tell the residents like take this tooth out like you're doing an immediate implant. Take this out like you're doing immediate. Like even if I'm not doing an immediate implant, I often do take it out like I am because I'm trying to save every scrap of bone that I can. So,
For sure.
yeah.
That sounds exactly how I do it as well. Except I use the 89 and the 90.
Okay.
I think you're using probably 87 and
Is
88.
that the more cupped one?
Yeah, I think
Yeah.
so.
Yeah. I'll have to try that. I'll have to try that. So I don't have those in my office, so I'll have to get that. So
But yeah, same concept. Like I'll use it to loosen the tooth and sometimes it comes out, but a lot of times it doesn't, and then it's
you
sectioning.
have to stop, otherwise everything goes. It just turns into chaos, right?
Yeah,
If
the whole
if you,
buckle
if you try to
plate can
rip, yeah, you
break
don't
off. Yeah, no,
want yes.
for sure.
It's a
Uh,
mess. Yeah, no messes. We don't want messes for people.
yes. Another question. How about best movie or TV series you've seen in the past
Oh
year?
yeah, um, probably one of my favorite. So you guys know Home Alone, right? Most people
Oh,
do, I'm sure,
yes.
right? So
Yeah.
I like the adult Home Alone. Have you heard of the movie Nobody? Oh my goodness, that
Is
is
that good?
the craziest one. And then if you want to get crazier, then watch Sisu,
Okay.
which is so Nobody's the adult one, and there's a second one. It was so popular. It's the Better Call Saul lawyer guy and then the follow up to that, if you want to see something even crazier, then watch Sisu. That is the Finnish uh, World War II Home Alone, which is great. So, and then I've been watching Stranger Things since the beginning,
Oh, yeah,
and
same.
I finished that with my kids. Like that was something I finished with my kids and
Yeah.
enjoyed that. But typically what we like to watch at our house if we're all watching together. So if you have families, these are the best series for families. You ready for this? This is gonna be great. The middle, all of my kids have the middle memorized. All of my kids have Malcolm in the middle memorized as well. And we all have psych memorized.
Oh, really?
Psych is one of hands down one of the best. It's one of the best shows I've ever seen. So, and we
Wow.
rewatch it all the time, all the time.
Well, that's a great
So good.
recommendation.
So,
Okay. Um, Next is, what is your favorite quote? Do you have like a quote or a mantra that you repeat to the residents?
my favorite quote. I mean, how do we say it? I mean, it's just do the right thing. It's
I
never
like
too late to do the right thing, right? So when is the right time to do the right thing? Right now. Just do the
uh,
right thing.
love it.
Yeah, you've got like I think that's probably one of the best things. You know, when we're talking like what's the right thing to do? What's the right thing to do right now? Then we got to do that. We got to do that. So, and then I'm also a Christ follower too. So I mean, I could you know to talk about that as well too. You know, I can do all things through Christ through strength. You know those
Yeah.
sort of things. You know, I was just Dr. O'Rourke, one of the orthodontists. It's funny. I was like, I'm doing a podcast, and he's like, I've never done this before. I was talking to him. He was in my office earlier this morning. We are talking because he's just across the street, and he goes, I'm gonna be talking about one. I'm going to be on one here pretty soon too. They want to talk to me about DSOs or this and that. So um, I don't know where I was going with it, but it was just he, um, um, he had a quote, and he was giving me several of them. One of them was um, he was talking about don't be anxious about anything. You know, that was one of his favorite things. Let tomorrow worry about itself. I think that's a good one. But he also did say. Um, he said he's low tech, high touch. Low tech, high touch. Isn't
Okay.
that cool? Because I
That
was
is
talking
cool.
about, I mean, talking about all the stuff I don't do anymore. He's like, yeah, I mean, you can get all this stuff, but I'm low tech, high touch, is what he said. And I thought that was good little insight uh, for dental. So he had other things too, like when you put a bracket on, you got to have the bad technique, which is bone a dry. When you put a bracket. There's other quotes too, but there you go.
Nice.
Oh man. So
Love it.
there's a whole bunch of other ones. How did this happen? How did this happen? There's several quotes with Dr. Lacasio. I can't think of the one that we said recently. I don't know. I'll if we ever talk again, I'll have it. I'm sure I'll talk to you. But anyway, there's several quotes. So I gave you a few there. Do the right thing. We got to get back to do the right thing. That was
Yeah. Love it. Last question is, what is your number one parenting tip for someone trying to raise kids?
so. Number one tip. I'll tell you what. Nothing good happens after midnight.
That's a good.
You'll use that in your later years. Nothing good happens after midnight. So um,
I
I,
like
th- I
that.
think that's a good one. But also, I'll leave you with something that my son I talked to him a lot about. Is you have the three bones. You have your funny bone, your wishbone, and your backbone, right? And they all kind of rest on your backbone, right? You've got to know who be confident in who you are, and um, people try to get you to do something some way that maybe is not the best thing to do. Pull out your backbone. So
I like
because
that.
he just went off to college, so yeah, that's good. There's others though I could think. I was just I don't even know why I had this up on the top. It's funny that you asked that. Um, I have these like things that I tell my kids every night, like God loves you. That's the only thing that makes you special. Just I mean, kids will do that they want to do.
Yeah.
Um, I don't know. I'm just trying to think of. There's a whole bunch of things. One other thing that's really good is saying yes to one thing means saying no to something else.
I love that.
I was just looking through that list quick. Saying yes to something means saying no to something else. So you may feel like, Well, I said yes. I said I would do it, but you have no idea what it did to your family. You have no idea what it did to relationship with a friend. Like there's other things to consider than yes, I'm gonna do that, no matter
Yep.
what. And what I would say to residents and to young surgeons, this is really important. I highly recommend getting an executive coach
Okay.
because your life will get out of balance super fast. So I've seen a lot of colleagues get divorced, seen problems that come up, and you think to yourself, I'm in practice, and you're thinking about your family like, I'm doing this for you. I'm doing it like there's this the internet meme, I'm doing this for you, and you find out that's not what they want from you. That's not what your
Yeah.
wife wants. That's not what your wife needs. That's not what your kid wants. That's not what your kid needs. Like you may think you're doing everything right, but that's where an executive coach can come in from the outside and say, are you sure about that? Are you sure about that? That's like, the Roman generals, who have the people whispering in the back during their triumph that say, you're human, you're mortal, you have a family. Think about the bigger picture.
Where do you recommend people find an executive coach?
So funny you should say that. There's coaching programs at universities a lot of times. So you could check within your town. You can check. They're usually plugged in with like chamber or a church would have executive coach contacts. I'm sure. I got an executive coach in 2012 because I thought I was doing everything perfect, right? And that's I wasn't. Right. And the way that I met him was through, I did leadership Oak Ridge through the chamber. I got to find out all about Oak Ridge. Oak Ridge, if people don't know, was where the Manhattan Project took place. Is one of the primary sites. And it's just up the road from Knoxville. And I practiced in Oak Ridge for a while. And I did this program, Leadership Oak Ridge. And one day, the leadership coach got up. We were down in Gatlinburg. I think it was after the fires or something like that. Or it wasn't, maybe it wasn't the fires. It might have been, there was some big catastrophe that happened. I just remember in Gatlinburg, which is where Dollywood is at and all those things. Okay. And they said, well, our speaker is Chuck Carringer is his name. And I can get you his info too. And he can get you plugged in with the coach probably too, if you want to. Because there's an executive coaching program at UT and he's been through that. But he stood up and he goes, are you feeling like this? Or are you feeling like that? And I'm like, I identify with all of these things that you're saying. He said the first like 5 people that email me, and I had a BlackBerry at the time or a smartphone. It might have been an Android. It was an Android at the time because I'd graduated from the BlackBerry. But I immediately emailed him and said, I need help. And he sat down. It was great. It was several years, probably about 4 or 5 years, just kind of, it's like having a counselor, but with goals, like we're like actionable. Like these are things I'm working on in my practice and going out and doing stuff, right? These are things I'm working on in my family. These are things I've worked personally that I'm working on. And I highly recommend that because you can get out of whack.
Oh yeah.
You think you have to treat everybody and everything when you get out. At least I felt that way. And you're marketing to everybody and everything. And I felt that need to go out and do this. And there's certain things you can do different. And bless you too. Sorry about that, Grant.
Yeah, that's fantastic advice. I really like that. Yeah. I think too, just the nature of our job and probably the nature of how most of us are, we're pretty driven people,
Yeah.
Surgery provides so much potential drive, but too much hyper focus can throw the rest of your life out of whack, your family and all that.
Yeah, I don't think anybody's immune to that at all. Nobody's immune to that.
Yeah. Well, this has been such a pleasure. I've learned a ton of stuff. Thank you for sharing this with myself and our listeners. This is awesome. What a great conversation.
Really appreciate you too. Thank you very much for having me on. Thank you so much.
My pleasure. Well, let's reconnect sometime. Thanks so much.
Sounds good.
Tennessee.
Sounds good. All right, man. Have a blessed day. Thank you.
You too. Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayOralSurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.